In this part of Chapter 3 for the UHDDS, we're going to talk about other diagnoses. And the UHDDS definition includes those conditions that affect the hospital care in terms of needing clinical evaluation, receiving therapeutic treatment, requiring further evaluation either by diagnostic studies, procedures, or having a consultant come in, conditions that extend the length of the hospital stay, and conditions that increase nursing care and/or require other monitoring. So it's important to remember that diagnoses that do not have an impact on the patient care during the specific hospital stay are not reported, even when they are present. And diagnoses that relate to an earlier episode of care and have no bearing on the current hospital stay are not reported. It's important to know or realize that physicians sometimes include these in the diagnostic statement and refer to them as historical information or status post procedures performed on a previous admission, but they have no impact or bearing on the current stay, so such conditions are not reported. History codes, which code to V10 to V19, may be used as secondary codes if the historical condition or the family history has an impact on the current care or influences the treatment. Many times the facilities have internal coding policies which will govern when and if they report hospital or history codes, and even state which history codes they do report. Generally, if a physician has included a diagnosis in the final diagnostic statement, it should be considered for coding. If there is no supporting documentation in the medical record, however, the physician should be consulted as to whether the diagnosis meets the criteria. And if it does meet the criteria, the physician should be asked to add the additional documentation or the supporting documentation. Reporting of conditions for which there is no supporting documentation is in conflict with the UHDDS definition and criteria. Sequencing of the other diagnoses have no specific rules or coding convention. However, the more significant diagnoses should be sequenced early or up higher in the list when the number of diagnoses that may be reported is limited. You can identify the more significant diagnoses by a CC, complication comorbidity, or MCC, major complication or comorbidity notation within the tabular index next to the code number. When using a grouper or an encoder, these are also flagged, and groupers generally will sequence these codes appropriately towards the top of the list. So just to recap, we also have chronic conditions such as COPD that may not be the thrust of the treatment and may not be treated within the episode of care, but they are reported because they may require evaluation and monitoring. So things for us to think about is the severity of the condition, the use or consideration of alternative measures, the fact that it increases nursing care or requires modification of the nursing care plans, requires close monitoring, or may even require additional testing or therapeutic services. Some examples of conditions that are integral to the disease process. An example would be a patient was admitted with nausea and vomiting due to infectious gastroenteritis. The nausea and vomiting are common symptoms of infectious gastroenteritis and should not be reported. Another example would be a patient seen in the physician's office complaining of urinary frequency and was diagnosed with a BPH, benign prostatic hypertrophy. Although urinary frequency is a symptom of BPH, both conditions are reported because of the instructional note in the tabular list under the code 600.01. An example of a condition not integral to the disease process is as follows. A 5-year-old boy was admitted with a 104-degree fever associated with acute pneumonia. During the first 24 hours, the patient also experienced convulsions due to the high fever. Both the pneumonia and the convulsions are reported because the convulsions are not routinely associated with pneumonia. Fever is commonly associated with pneumonia, however, and is not coded. So let's talk quickly about abnormal findings. Categories 790 to 796 for nonspecific laboratory or abnormal findings includes laboratory, radiology, and pathology, and other diagnostic results. These codes should be assigned only when the physician has not been able to arrive at a related diagnosis, but indicates that the abnormal findings is considered to be clinically significant by listing it in the diagnostic statement. This differs from the outpatient setting coding of diagnostic tests interpreted by a physician. Codes should never be assigned based on the basis of an abnormal finding alone, so you can't see it in a report and add it automatically. When findings are clearly outside the normal range and the physician has ordered other tests to evaluate the condition or has prescribed treatment without documenting an associated diagnosis, it is appropriate to ask the physician whether a diagnosis should be added or whether the abnormal findings should be listed in the diagnostic statement. Incidental findings on X-rays should not be reported unless further evaluation or treatment is carried out. So let's talk quickly about the admitting diagnosis. The inpatient admitting diagnosis is not an element in the UHDDS, but is required for some payers and is used in determining quality of care services, may also be the first step in utilization review process. An inpatient admitting diagnosis may be a significant finding such as a symptom or sign representing patient distress or an abnormal finding on an outpatient examination. A possible diagnosis based on significant findings, or a working diagnosis. A diagnosis established on ambulatory care basis or during a previous hospital admission, an injury or a poisoning. It may also be a reason or condition not actually an illness or an injury, such as a follow-up examination or a pregnancy and labor. The code should indicate the diagnosis provided by the physician at the time of admission. The admitting diagnosis might not agree with the principal diagnosis on discharge. The admitting diagnosis should never be changed to conform with the principal diagnosis. The UHDDS definition of a significant procedure is a procedure that meets any one of the following criteria or conditions: is surgical in nature, carries an anesthetic risk, carries a procedural risk, or requires specialized training. Surgical in nature includes items receiving incision, excision, destructions, amputation, introduction, insertion, endoscopies, repairs, sutures, and manipulation. Carrying an anesthetic risk is a procedure performed under anesthesia other than a topical agent. Procedural risks are any procedure that has a risk including functional impairment, physiological disturbances, or possible trauma during an invasive procedure. And specialized training performed by specialized professionals, qualified technicians, or clinical teams specifically trained to carry out or perform certain procedures. In contrast to inpatient coding, no after-study element is involved in the outpatient definition because ambulatory care facilities do not permit the continuity evaluation ordinarily needed to meet the UHDDS definition or criteria. If the physician does not identify a definitive condition or problem at the conclusion of a visit or an encounter, report the documented chief complaint as the reason for the encounter or the visit. Next, we need to discuss the ethical coding and reporting. Medicare reimbursement depends on the correct designation of the principal diagnosis and the presence or absence of additional codes and the procedures that are performed. Ethically, we cannot add additional codes when there is not supporting documentation, as we just discussed. It is also unethical to remove or not to code a condition that has been considered significant by the physician. It's important to remember that other third-party payers may follow slightly different reimbursement methods, but the importance is that we should always code the ICD9 CM as accurately and as completely as possible. So accurate and ethical coding depends on our ability to correctly follow all of the instructions within our coding manuals, within the official guidelines, and the AHA, the American Hospital Association's coding clinic for ICD9 CM. It requires correct selection of conditions that meet the criteria set by the UHDDS and the official coding guidelines. So as I mentioned just a couple seconds ago, overcoding and undercoding is unethical and may be considered fraudulent. Failure to include all diagnoses and procedures that meet the criteria could result in financial loss for the provider. Coders should abide by the AHIMA standards of ethical coding. Medicare has also identified certain conditions as unacceptable as the principal diagnosis, and many of our publishers have added that element to the tabular list. So it's another important reason for us to always move from the alphabetical index to the tabular list to confirm my diagnoses. It's important to code correctly and then make whatever adjustment is required for reporting. Otherwise, you, as the coder, run the risk of developing incorrect coding practices that will distort data used for other purposes. A facility may collect non-reported diagnoses or procedures for internal use if the information is maintained outside of the system used for external reporting.